think all of us who have been subjected to managed care feel like we'd like to get the guys that pushed us into this and wonder, if there is some way to do that, because we really have been going under a lot of rapid changes in healthcare, and there are a lot of things to think about. And a lot of my friends who are physicians that are around my age, which is pushing 50 quickly, are ready to have a different career. A lot of my nursing friends say they'd like to get out of the situations they're in because they're finding things increasingly difficult. In fact, somebody shared at supper last night that they're working in an operating room and now the nurses are cleaning the operating room. I think we have really moved a long way in this cross-training idea and changing what people's roles are. Since I practice in 3 states, as you were already told, I also go to conferences in all 3 of those states and talk to a lot of people in different professional organizations. And so I get a pretty good sense of what people are thinking in my little corner of the Northeast. And one of the conferences that I went to last fall was entitled The Death of Managed Care. And it was put on by the New Hampshire Psychological Association. And they had an attorney come and speak, and his name was Brian Welch. And he has something in common with me. He started out in healthcare and then went into law. So he's a dual career professional, only he was a psychologist first and now is an attorney. And he was talking about all the ways that plaintiffs' attorneys can sue managed care organizations. And he kept referring to a number of acronyms that I didn't recognize, and one of them was SST. Now, I don't know how many of you are involved in mental health and recognize the acronym SST, but it stands for single session therapy, because that's what many managed care plans were allowing, is one session of psychiatric mental health therapy, and that's all they would pay for. And if you wanted anything more, it was going to require a miracle. So there was a lot of interest in what he had to say, because he was really saying that the only way he felt that managed care was going to change was by plaintiffs' attorneys bringing a lot of lawsuits. And plaintiffs' attorneys in Massachusetts, I know, are really looking towards bringing lots of lawsuits. In fact, at a conference that I was at about managed care malpractice, a number of the plaintiffs' attorneys were talking about what a fertile ground managed care capitation was for litigation. In fact, they viewed it as the goose that laid the golden egg, or an insurance policy for their retirement. So they were really pleased about what has happened to the healthcare system, because it's just really going to allow for a lot of litigation in the future. And people are developing many new theories of liability, and I'm sort of going to breeze through some of those theories a little bit later in this talk. I haven't personally had any managed care liability cases come into my office, but I have talked to colleagues in other parts of the country who are beginning to see more and more of these cases. I just want to take a minute to talk about what has been happening in general in medical malpractice cases. And what we're seeing is that there are increased settlements in terms of the dollar value. There may not be any more, but the dollar value is getting higher. And the jury verdict research study that was released on June 18th of this year showed that the median malpractice award, this would be a jury verdict, reached $568,000 in 1996, and that's up 90% from what it was in 1988. So the verdicts are getting higher, and there's more at risk from a monetary sense. I think it's pretty instructive to look at why people sue. And there was a study done a number of years ago by the Chicago Risk Pooling Program, and it gave a listing of a number of reasons that people sue. And the number one thing on the list was anger and frustration. And I think that's very interesting, because if we listen to the complaints that consumers are having about managed care, and we know how we as healthcare providers are feeling about managed care, there's a little bit of anger and frustration about delays, about care that will not be provided under plans. In fact, a study of consumer complaints in California HMOs in 1996 showed that there was an increase of 18% over consumer complaints that were filed in 1995. So consumer complaints are really rapidly on the rise, and you're going to see with the rise of consumer complaints that there is also a rise in litigation. The second thing in the that the Chicago risk pooling study showed was the we-them syndrome. And this happens when a patient feels that an incident has occurred that shouldn't have, that there was a bad outcome, and then the provider digs their heels in and will not be responsive to the patient. And I think as Christian healthcare providers, we always need to be responsive to the patients, even if something bad has happened. In fact, I found experientially that when healthcare providers have been really honest and upfront with patients, even when something bad has happened, those healthcare providers don't get sued. It's a really good risk management technique, and it's a really good thing to do as a Christian, to be compassionate and understanding, and also to be honest. The third reason for people to sue was pain and suffering, and that's pretty obvious why that would be a reason, and it really doesn't change much with managed care. The fourth one was no response by the healthcare provider to problems being experienced, and that really, the ideas there are similar to the second one that I talked about. The desire to recover for financial loss, mistakes or incompetency. Now the seventh one is consumer fraud, and this is a little bit interesting because this particular problem comes about because we in healthcare are so good about billing even when something bad happens. And someone had told a story about what he did for his doctoral dissertation, and it was a study of 7 cases where women had breast cancer and actually had the wrong breast removed. And he found in every single one of those cases, even though it was well recognized that a mistake had been made, that all the bills from all the specialists from all the facilities went out to those 7 patients, and they all sued. Well, you know, that's the surest thing to trigger a lawsuit is a huge healthcare provider bill when something bad has happened. The 8th thing is the professional recommendations to sue, and that would include both recommendations from attorneys and recommendations from healthcare providers themselves. And I think as Christians, we really need to be careful that we don't jump on the gun and say, oh, that person did it all wrong, they should never have done that, before we really know exactly what they did. Because as I have found from many years of experience, even though the documentation is supposed to tell all the information, it doesn't always, and it's good to check it out before you get somebody else in trouble and get them sued. The 9th thing was a lack of informed consent, and that becomes of a particular problem with some of the managed care agreements. If anybody has a gag clause and they're not supposed to be giving certain information to patients, that can become a problem under managed care. A lack of willingness by a provider to tell a patient that he or she was involved in an incident, and that goes back to the basic need for honesty. I want to take some time and look at some of the major managed care malpractice cases that have occurred. Probably most of you are familiar with the HealthNet case, which was the California case in which there was an $89 million verdict. And in the HealthNet case, the HMO had refused to pay for a bone marrow transplant for a breast cancer patient that had died. And the jury found that HealthNet had breached its covenant of good faith and fair dealing, and that it had inflicted emotional distress through what they termed a reckless denial of coverage. And of the $89 million, $12 million of that was in compensatory damages, and $77 million was in punitive or the punishment damages. And the thing about the HealthNet case that is important is not the size of the verdict, because you're not going to see that type of verdict or that type of settlement in many managed care malpractice cases. What's important is it points out how the jury was feeling about the decision making. And even though jurors are supposed to be impartial fact finders, we know that their perception is colored by what they know is going on. And a lot in doing jury polling after managed care cases have gone to trial, the attorneys that have been involved have found that the jurors feel that healthcare has now become big business, that it's a for-profit enterprise, and that they are going to award monetary damages in concert with that concept, and that if they're not happy with managed care as an overall thing, that they are going to award high verdicts. So I think that that will be a trend that will continue unless there is a correction in what is happening within healthcare. And many of you out there probably can provide some of the solutions to make that type of correction. The case of Wickline versus State is probably the leading case to discuss the liability of a managed care organization for improper use of cost containment procedures. In the Wickline case, the plaintiff, Mrs. Wickline, was having circulatory problems in her leg, and her doctor had asked to have her length of stay extended for another 8 days. The managed care organization said that they would only extend it for 4 days, and she was discharged despite her protests. Well, what ended up happening was that she ended up with a massive infection in her leg and ended up having her leg amputated. And the verdict in that particular case was quite high. And in the Wickline case, when it was appealed to a higher court, the appellate court said that the decision to discharge Mrs. Wickline was that of her treating physician, and that cost limitation programs should not be permitted to corrupt medical judgment. And there was actually a verdict against her physicians, not against the HMO. And the court set forth a standard in that particular case, and the standard is the patient who requires treatment and who is harmed when care should have been provided and is not provided should recover for the injuries suffered from all of those responsible for the deprivation of such care. Third-party payers of healthcare services can be held legally accountable when medically inappropriate decisions result from defects in the design or implementation of cost containment mechanism. However, the physician who complies without protest, and I think that's really important for you as healthcare providers, the physician who complies without protest with the limitations imposed by a third-party payer when medical judgment dictates otherwise cannot avoid his ultimate responsibility for his patient's care. So physicians can't use the excuse that the managed care organization was dictating what they were doing. Nurses cannot use the excuse that their hospital was dictating what they were doing, or nurses also cannot use the excuse that a physician gave them the order to do that, because if you as a nurse know that it's wrong to discharge a patient, even though the physician has written the discharge order, I'll tell you, you better challenge that order and see that that patient is not discharged if it's not safe, because that's part of your appropriate standard of care. There are many managed care cases. Another sort of category of managed care cases involves improper triage of patients. And one case in point occurred in Massachusetts, and it involved a patient who ended up suing their HMO when, after a period of 5 years, nobody had appropriately diagnosed why this woman had a lump next to her navel. And her primary care physician was assigned to her, but never saw her except one time during the course of this 5-year period. She was seen by numerous different nurse practitioners and physician assistants. There was no continuity in who she was seeing. She did see her primary care physician once for a 15-minute visit. Well, to make a long story shorter, the patient was finally seen by another HMO physician, not the one that she was assigned to, and he immediately found that she had metastatic ovarian cancer. And she underwent numerous surgical procedures, but because of the long delay, her prognosis was poor, which would be expected. And the case was settled in 6 weeks before it was scheduled to go to trial for $1.5 million. A number of commentators that looked at that case said that the problem with the case was that there was inappropriate delegation. However, from my perspective, the problem with that case was that there was not continuity of care, that nobody was really making sure that there was adequate follow-up. Somebody new kept seeing her all the time, and no one determined her problem until it really was too late. The 15-minute visit by her primary care physician reminds me of a question that was asked a couple of years ago at a meeting of the American Society of Law, Medicine, and Ethics, and a physician got up and asked a panel, and he said, "I work for an HMO. They have now told me I can spend no longer than 15 minutes with any of my patients. So how can I safely practice medicine?" Well, I didn't answer his question, but my answer to that would have been that you can't safely practice medicine, because how are you going to do an adequate health history on a complicated patient, do an appropriate physical exam, and then do the follow-up instructions necessary with the patient in 15 minutes. Now, certainly you may be able to do a follow-up check visit in 15 minutes, but certainly not an initial visit. And he was being asked to do initial visits within 15 minutes because they felt that you could do it that way and that would be cost effective. But that certainly does open up people to suits. Going back to the difficulties encountered with triage, there also is the problem when patients call and talk to a triage telephone nurse. And in one case, which is Adams versus Kaiser Foundation Health Plan of Georgia, there was an ill 6-month-old baby that had been seen by one of the Kaiser physicians, and the Kaiser physician, in essence, minimized this baby's condition. The baby got worse, the parents were concerned, they called and talked to the triage nurse. The triage nurse really did not get adequate information with them, and from them. She called the pediatrician, relayed the information that she had gotten. The pediatrician thought the child needed to be seen, but there was no extreme urgency, so they sent the child with its parents to an emergency room that was 42 miles away from their home, because that was the emergency room that was covered by their managed care plan. 30 miles into the trip, the child arrested. The parents immediately got off, went to the closest emergency room. The child was resuscitated, but unfortunately the circulation never returned to the child's extremities, and the child ended up with a quadruple amputation of his hands and feet. And the jury returned a verdict in that case of $45 million. Another case that involves similar circumstances in terms of emergency rooms is Dirmus versus AdMed Incorporated. And in this case, there was a female patient who was 5 months pregnant, and she was in an automobile accident. And she was immediately taken to the nearest local emergency room. And when she was taken there, they contacted her managed care plan, and they said, "Oh no, she can't stay here." Well, through some miscommunication, she was transferred to several other hospitals, and she had a back injury, which she later claimed was unstable. And by the time they fooled around and transferred her and delayed inappropriate treatment and never stabilized her between emergency rooms, she ended up with some significant disability. And she and her husband brought suits in court alleging both malpractice and also alleging violation of the federal EMTALA anti-dumping law. Well, the court ruled that EMTALA did not apply in this particular case because it only applies to hospitals dumping patients. It doesn't apply to HMOs or managed care organizations saying the patient can't stay there, because it was the managed care organization that was making the decision. And there was nothing in federal law to protect the patient in that particular case. In terms of her claims of malpractice against the managed care organization, the court ruled that it was preempted by ERISA. Now, ERISA is the Employment Retirement Income Security Act, and I always have to read that or I forget what it is. But it contains provisions that say that you cannot sue an employee benefit plan for the administration of the benefits. And what the court said was what the managed care organization was doing was administering the benefits of the patient's employment benefits plan and could not be sued, even though they were making some health care decisions. And ERISA preemption is something that has been an important consideration in bringing managed care malpractice claims against managed care organizations, because when federal law says that you can't sue someone, even though you have state law saying that you can, the federal law is the ruling law and will preempt the state law. So that was what happened in that particular case. Another example of the ERISA preemption is the case of Corcoran versus United Healthcare. And in this particular case, a physician recommended that his high-risk pregnant patient spend the last month of her pregnancy in the hospital. And the managed care organization that she was insured under thought that spending full time in the hospital was too much, so that they agreed that she could have 10 hours a day of home health nursing observation, assessment, care. And so, of course, that left her 14 hours a day when she was covered, and the inevitable happened. When the home health nurse wasn't there, the baby went into fetal distress and the baby died. And so the parents sued because they said that the managed care plan had committed malpractice. Well, the managed care plan said that ERISA preemption applied because that they had not made a medical decision, but merely had determined whether or not the patient was eligible for benefits. The court went on to rule that the managed care organization did make medical decisions, but that the medical decisions were made in the context of determining whether or not benefits were available for that specific types of care. And for that reason, the wrongful death claim that the people brought under this, their state law was preempted by ERISA in the Corcoran case. Since Corcoran, we have had a number of cases that have had different rulings and that have allowed people to sue even though there is the specter of ERISA preemption. And there are three situations in which most of these cases have been decided. And one is when the state law claims against the HMO don't rest on the terms of the managed care plan. In other words, there are no provisions of the patient's managed care plan that would preclude the patient from suing. And the next one is when it's alleged that the HMO is vicariously liable for the alleged malpractice of one of the physicians. And this would be in situations where the HMO can be held responsible for the acts of an employed physician. So in that case, there would not be ERISA preemption. And the third thing is when claims for medical malpractice against HMOs are for the quality of medical care provided by the physicians versus the claims that the plan erroneously withheld benefits. So if the claim is really that the physicians didn't provide the appropriate quality of care, the HMO can be sued. As I said, there have been a number of emerging theories of liability as a result of managed care, and I'm just going to go through these very quickly and not to get into a lot of examples. But negligent choice of a specialist, not knowing who the specialist is that you're referring people to, or not being able to refer to the most appropriate specialist in your area because they're not a member of the panel. Negligent failure to refer to a specialist, perhaps your managed care plan is giving you financial incentives not to refer to a specialist. Premature discharge, this would both be from hospital or from outpatient care. Failure to provide treatment. Negligent credentialing is becoming a big issue in terms of managed care plans not appropriately credentialing their physicians. Decision making by non-physicians, and really relegating a lot of decision making to non-physicians that should not be at that level. Refusal to admit to a hospital. We saw that with some of the ER cases. Limitation of benefits, the experimental or non-approved procedures, which goes back to the, what the HMO was saying in the HealthNet case, that bone marrow transplants were experimental and they weren't going to approve it. Non-disclosure of research interests. And then a big category is lack of communication, which is always a big problem in any kind of malpractice action. But now there have been problems with unavailability of medical records, problems with the coverage arrangements, and the continuity of care, which we saw in one of the cases I mentioned earlier. Breach of the contract to provide care. These are many of these. Some of them we were seeing before as causes of action, but a number of them are unique to today's managed care environment. Defective equipment or facilities, inadequate enactment or enforcement of practice guidelines, or inadequate or unacceptable practice guidelines. Non-disclosure of financial incentives to treat, and lack of informed consent due to prohibitions against discussing some of the treatment options that would be available to patients. So those are some of the theories of liability, and there are additional theories that are out there that are emerging as a result of the managed care environment. And there's special liability issues that are involved in the gatekeeper position. And whenever a primary care physician decides that they are going to become a gatekeeper in a managed care organization, they really have to think about what kind of patient population they're going to serve, what kind of information that they're going to have, because they're going to get themselves into situations where they're going to be asked to approve or deny care, even if they don't have specific knowledge of that particular individual patient. This becomes really problematic in emergency situations. It makes the decision-making process difficult, and mistakes in the decision-making process are obviously going to lead to allegations of malpractice. The gatekeeper also needs to be cautious about knowing the quote-unquote rules of becoming a gatekeeper and what's really involved. And I find a lot of times that in talking to friends of mine who have entered into managed care contracts, that they really haven't totally read the contract. They've signed it and they haven't thought about it, and you really need to know what you're getting into. You can't just have a general discussion. Read the fine print and have an attorney review the contract for you before you decide exactly what you're doing on any managed care contract, even one that you're renewing, because the provisions may have changed. And you can get yourself into liability situations that you don't want to be in. Another thing that has happened is that primary care physicians may be asked to do procedures that were previously done by specialists. And if you're in that situation, you need to be sure that you have the requisite knowledge and training to do it, because you're going to be held to the same standard that the specialist is if you're doing a procedure of that nature that had always been done by a specialist. And as I had mentioned before, managed care organizations are incurring liability for employing gatekeepers who do not have the appropriate credentials. So those are all special liability issues that relate to that particular position. One thing that I always wonder about is what the impact managed care is going to have on the standards of care. And I really think that it may effectively erode what we today consider the standards of care in medical practice, nursing practice, or in the practice of other ancillary health care providers. And managed care organizations are developing their own guidelines. I'm sure many of you have heard it referred to as cookbook medicine. There are also many professional organizations that are developing clinical pathways and practice parameters. And some of the guidelines that are set up by the managed care organizations are in real conflict with those set up by the professional organizations. In fact, I recently read a report that was done of a study that was done of surgeons across the country who were really upset about the managed care companies only certifying a one-day length of stay for so many surgical procedures, or a two-day length of stay, and that this was absolutely unsafe. And I know from two recent experiences with my own family and friends that In one situation, someone was discharged post-hysterectomy too soon, ended up in the hospital less than 24 hours later with significant complications. In another case, someone was discharged post-bypass surgery within 3 days and ended up with numerous complications, rehospitalizations, premature discharges again, and eventually he died. And I don't think he would have died if it had not been for all the premature discharges, because he was never ready to leave the hospital at any point in time when he was discharged. I think one problem that we really have in talking about the standards of care is that we don't really have enough data to say that the managed care companies or managed care organization guidelines are wrong. We do have some data in some areas, but we've never collected and cannot clearly articulate why some of their guidelines are wrong, and we need that objective data to be able to challenge them and effectively argue that. In Maine, where I live and where I do the majority of my practice, we have a medical liability demonstration project that's going to the year 2000. And as part of that project, we've set up practice parameters in 4 areas: in emergency medicine, radiology, anesthesiology, and OB-GYN. And this has been set up by the specialty groups within the state. And any physician who is participating in this particular medical liability demonstration project and following the practice parameters, if he follows those practice parameters and then is sued for malpractice, the fact that he followed the practice parameters becomes what is called an affirmative defense. In other words, the plaintiff's attorney cannot prevail in court against him as long as he followed those practice parameters to the letter. But I sit on the advisory committee for that demonstration project, and unfortunately we've been really disappointed because we just haven't been having enough happen to get enough data to say whether or not this is being effective in terms of a tort reform action. There also, as a result of managed care, has been legislative attempts to deal with the complex liability issues raised by managed care. Everybody's familiar with the legislation that has resulted as a result of the so-called drive-through deliveries or the drive-through mastectomies. And I think we're going to see more legislative action about specific health care issues than we've ever seen in the past. Last year, there were 40 states that passed laws on HMO consumer protection, and many states are in the process of passing additional laws. This year, in May, the state of Texas passed a law that allows HMOs and other managed care entities to be sued for medical malpractice, thus making it easier for managed care organizations to be sued in the state of Texas. And as soon as they passed that law, the Aetna Health Plans of Texas sued the state of Texas in federal court in an attempt to block this new law. And I really don't know what's happened. That happened in June in terms of that suit was brought. I don't have the outcome of that. But lots of bills are going to be introduced and will continue to be introduced. In closing, I just want to tell you a little story to sort of summarize some of my thoughts about this. One day there was a little boy walking home from school, and on the way home from school he found a baby bird. And he thought, well, I'll pick up that baby bird and I'll take that bird home and show it to my grandfather. So he carefully picked up this baby bird. And on the way home he decided, well, I'm going to ask my grandfather if this bird is alive or dead. And if he says that the bird is alive, I'll crush it in my hand and it'll be dead, and he'll be wrong. But if he says that it's dead, I'll open my hand and show him that the bird is indeed alive. So when the boy reached home, he proceeded to ask his grandfather whether the bird was alive or dead. And his grandfather, being a very wise and sage old man, said, "It's as you will, my son." And so it is for each of us as we interact with managed care. We have the power to make decisions, we have the power to lobby in a political sense, and we have the power to be advocate for patients. And how we use those powers is going to be up to each of us as individuals. And those of you that are healthcare providers have the power to avoid professional liability. You have the power to be effective advocates for your patients. And how you do that is something only you can determine. But my prayer for you is that may God grant each of you wisdom and strength as you deal with today's managed care environment, and you make decisions for your patients, or you make policy decisions that is going to impact healthcare in the United States. Thank you. Okay.
Thank you very much. We have time for a question. Does anyone have one?
Good. Nobody does. Oh, she does.
I'm Claudia Peterson. I'm a general internist. A question just on a practical level. If we are ready to discharge a patient, or a nurse is participating in the care of a patient, and the HMO says, the patient we feel needs another day or two, and the HMO says, no, it's time for the patient to go home. What on a practical level are we to do? Do we discharge them telling the patient we think they're not ready to go? Do we document that we are discharging them against our better judgment, or do we keep them and say, well, we'll worry about what the HMO says later?
Basically, what I think in that particular situation is that if you don't think the patient is ready to go, and you have medical reasons why the patient is not ready to go, you need to find some way to keep that patient in the hospital. And whether that is that you get the patient to agree to private pay, or if you get the hospital to agree to write off the bill, or you arrange something. But if the patient's not ready to go medically, that patient shouldn't go. Because if you discharge a patient prematurely and they end up with a bad outcome and they sue you, according to current standards of care, which have not totally been eroded by managed care yet, you're going to be liable for that decision, and you shouldn't discharge the patient, because why do you want something bad to happen?
So even though in a sense our hands are tied,
yes, I think in a sense your hands are tied, but as far, I guess, I'm probably too much of an idealist. I don't think your hands are ever tied. There is always a way to work it out. And I think hospitals don't want to be sued for malpractice any more than you as individual practitioners want to be. And they're going to be liable if they don't figure out a way to have that patient's length of stay extended. And I'll tell you, writing off $700 or $1,000 hospital bill is a lot less expensive than one day spent in depositions. So,
thank you.
And then we have one question here and then one over there, and that probably may be all we have time for.
I'm David Smith of Little Rock, Arkansas. This is an ethics conference. Of course, I've never been in that situation, but some of my colleagues have made mistakes. What is your best counsel for physicians who find themselves who've made a mistake, who consciously do not want to be deceptive, and yet have that great specter of malpractice hanging over them?
Well, I think as I earlier said when I was talking, that I found out experientially from looking at lots of malpractice cases and lots of potential malpractice cases all over the state of Maine. I've worked with all but one hospital in the state of Maine on that kind of issue. And what I've always told people is that if you are honest with the patient about what happened, and you are honest with the patient at the time that the incident occurs, and you do everything in your power to make things as right as possible, that the likelihood of your getting sued is very low. I mean, I have seen horrendous things happen in hospitals where into physicians in their practice, and have patients not sue them because they either liked the person so much, or they felt that the person was so honest and upfront and tried to help them at that time. So that's my best advice, is to be honest. And I also think that, as Christians, we need to be honest. And sloughing over things is not something that we should be doing. We need to be open and upfront.
I'm Dottie Sampson, nursing faculty at Schoolcraft College. My question is very similar to the first one, except from the nurse's perspective. If the physician has discharged the patient, but as I have been caring for the patient, I don't feel they're ready to go home, what recourse do I have, and what documentation should I do?
Most hospitals, you should have some sort of policy that tells you what the chain of command is if you think something is going on that's unsafe for a patient. And if you follow that chain of command it will bring you to someone else who is a decision maker other than the primary attending physician. And that person should be able to assist you in making sure that the patient is not discharged.